everyone, this is Professor Henriksen, and this is your lecture on perfusion. I am assuming that at the start of this lecture that you have completed your reading, that you've reviewed your learning outcomes and gone through your skeletal outline, and then you can use this lecture to continue that information transfer and add to your notes so that you're prepared for class. Any concept that we discuss in this class, I like to approach it from a standpoint of looking at the pathophysiology so that you really understand what's going on with your patient physically. And then from there, you'll know what to assess for. And if you know what you're assessing for, then you can understand what kinds of things your interventions need to be addressing. So the first thing we're going to dive into is looking at pathophysiology. It's helpful to make sure that you understand normal, quote, normal anatomy as blood flows through the heart so that we can understand exactly what might be going wrong in a patient that has something like acute coronary syndrome or dysrhythmia, as those are our examples today as we talk about perfusion. So you might remember from anatomy and physiology that you're going to have deoxygenated blood coming in through the inferior and superior vena cavas and into the right atrium. From the right atrium, blood is going to flow through the right ventricle and out through the pulmonary artery. The pulmonary arteries are going to carry blood into the lungs, and the lungs will circulate the blood and oxygenate it and return it back through the left atrium, and from the left atrium it goes through the left ventricle where it pumps through the aorta and then out to the rest of the body. What we run into is with, for example, in acute coronary syndrome, there's going to be a blockage in some blood vessel that serves part of the heart, and when that blood vessel is blocked, the myocardial cells die, and this creates scar tissue that doesn't work appropriately. That means that part of the heart is not giving a good squeeze of blood, and then this alters our perfusion because blood cannot circulate well throughout the body. Next, we will talk about the electrical conduction system in the heart, and these are the innate pacemakers that are naturally inside of the heart, and they control how electricity is controlled through the heart so that the different parts of the heart beat on time. So your atrium, the right atrium, has the SA node, the sinoatrial node. Electricity will carry from there. This is the heart's hopefully normal pacemaker in a normal healthy heart. Will carry the electricity through the atrium and then through the AV node. The AV node then carries the electrical conduction down through the septum and then through the Purkinje fibers. So in normal sinus rhythm, as we'll get into when we talk about normal sinus and all the rest of the rhythms that we need to be able to read, the impulse is going to come from the SA node and then carry through. And as the impulse spreads, that part of the heart contracts. So the SA node produces an electrical conduction that goes through the atrium squeezes, and then as the electrical conduction spreads through the septum and up through the sides of the ventricles then contract secondarily. That creates, actually, just make a mental note of this for later on in the lecture, that creates actually this pattern that we see on EKGs. So we can look at it like this. This first part of the EKG, this little blip here, that's when the SA node produces an electrical conduction, spreads to the AV node. This part represents when the atrium is contracting. From there, as the electrical conduction spreads through the septum and up through the Purkinje fibers, the ventricles contract. That's what creates this part here. This is your QRS complex. So we have our P wave and our QRS complex. Those are the first two parts. So we have atrial contraction, then we have ventricular contraction. Then we have the T wave. The T wave is where the the ventricles are recharging during the T wave. Now, the atrium, I always wonder about this. The atrium has to repolarize and relax as well, but that's happening actually during the QRS. Think about it this way. Your ventricles are so much larger as compared to your atrium that when those are having an electrical conduction, the result is so much larger. It's overpowering the atrial repolarization. These are your three main parts, so your P wave, QRS, and T wave. So I want you to be able to associate those parts of the EKG with the anatomical structures that are being used during those times. That will help you really understand what's happening physically to your patient when we get into the dysrhythmias.